Hello, in this video we will discuss about the pericarditis. Basically in this video the pathogenesis and clinical finding we will discuss. So first of all we should need to understand the overview. So basically the pericarditis means the thin layer is the outer which that is protective layer in the heart which that is inflamed or some problem which that will lead to pericarditis. So this is the heart which that contain a fluid in pericardial space act as a insulator. Basically it is here is the myocardium is inside while the pericardium is the outside, and between the inside of the pericardium, basically pericardium contain a fluid. So remember that pericardial fluid. So this pericardial fluid can be changed. The pericarditis tamponade with epicarditis or other problem which that can be arise the different. The pericarditis with the effusion. So in this way it can be effusion or pericarditis with no effusion. So basically it is no effusion. On the other hand, the effusion, so it can be problem for the heartbeat, and in this way the heart will be constrict more and not dilate. That is why the pericardial inflammation, the pericarditis, which that will lead to not relax the heart. It means the input will be decrease of the heart, so while the output will be increased due to the and not sufficient heartbeat during the rest time as parasympathetic time. So the pericardiocentesis which that will lead to hemodynamic consequences we will discuss here. So the hemodynamic consequences is the transient permanent constrictive pathophysiology. In this way the inspiration during the inspire the lungs will be more dilate. In this way the ventricular interdependence which that will lead to constrict the heart, and in this way the output will increase while the input will be decreased. In this way the complete filling of the heart which that will not occur due to the of the blood, while the expiration which that will lead to which that will lead to not feel the pain because the lungs will be closer, and in this way it is easier. So the accentuated early diastole feeling which that is here, which that is due to the lateral electrode and septate electrode which that is used for the depolarization, and in this way this is the normal will lead to constrict, and the not depolarization will complete. And the triphasic friction problem, the atrial friction, the ventricular contraction, and diastole filling, which that will be damage, and in this way the atrial friction which that will be increased. So on the other hand, here is the ECG we will discuss. So this is the pericardial fluid in pericardial space act as insulator. So that no it is basically in the functional, and in this way the heart which that eject the blood is more, but the input should be more, so input will not complete. So it can be occur due to the bacterial, viral, fungal, parasitic infection, 85% unknown, and systemic inflammatory disease like rheumatoid arthritis. A myocardial cell emit electrical signal which that will not complete constriction of the not complete the dilation of the heart, not constriction but dilation. In this way the problem which that will lead to heartbeat not completely more constriction but dilation which that will not occur. So in the ECG reading which that is the normal amplitude will be not in this low amplitude of the Q wave, and in this way the PQRST wave will be damaged. In this way the heartbeat which that will not completely dilation, and that is why the heart output will be increased but the cardiac input will be decreased, will lead to many complications. So let's begin to understand the pathophysiological process. So the possible pathophysiology, the one, reactivity of infection, antigens with body's own antigen, and the infection stimulates a host immune reaction, an unknown mechanism. But this will lead to pericarditis and the inflammation of the tissue sac that surround the heart, which that is called the inflammation surrounding the heart and the tissue. And in this way the heart which that will be problem. And the other factor is drug, toxin and uremia, radiation and neoplasm 1 degree or 2 degrees Celsius, and the direct trauma and surgery and the stabbing which that can also cause the pericarditis. So remember that things: drugs, toxin, uremia, radiation and neoplasm and direct trauma. And that basically is the inflammation of the pericardium which that will lead to constrict and inflame, will decrease the fluid, the pericardial fluid. And the pericardial fluid can be also increased due to the inflammation and secretion more uncontrollably. So the myocardial infarction and tissue necrosis and scars formation will lead to inflammatory markers generated the irritate pericardium, irritation which that is can create. And in this way, the inflamed, irritated visceral and parietal pericardia rub against one another, which that will lead to cause pain. And that basically is contact of chest wall when inflamed pericardium when lying down or from expanded chest volume during inspiration. So it will irritate during the inspiration because the lungs will be more dilate, and increase the volume of the lungs will decrease the space of the heart, will lead to rub to each other, and in this way the friction will be less, more. So the pericardial tissue with abrasive texture make audible noise, audible when rubbed together during heartbeat. So in this way we can listen through stethoscope to understand the pericarditis. And in this way here is sign can be the pleuritic chest pain with inspire, when we will inspire, because the constriction, the dilation of the lungs increase the volume, will lead to cause the problem. Audible triphasic friction rub on auscultation, and number one is the atrial friction, two ventricular contract and diastolic feeling, which that is basically a triphasic friction rub on auscultation. So in this way, here is the inflammation of the pericardium extends to myocardium also, will lead to widespread and inflamed the stressed myocardium also stress, and in this way the may increase the marker for cardiac injury, and the alter the ventricular repolarization. So alteration the ventricular repolarization will lead to not dilate or diastolic phase will be disrupt, and the increase the cardiac troponin I and T. On the other hand, the pericardium may thicken or scars with fibrosis following inflammation, which that will lead to constrictive pericarditis. And this is the complication due to the pericardium thicken or scar with fibrosis following inflammation will lead to constrictive pericarditis. Is the complication will lead to cause disease. Anyhow, let's more discuss about this is the inflammatory cells serum accumulate in the pericardial space, and accumulate in the pericardial space will lead to complication, the pericardial effusion. The pericardial effusion increase and pericardial fluid in the space will increase. In this way you can understand the increase the pericardial fluid in the space. So when increase the pericardial fluid is known as the pericarditis tamponade with pericarditis with effusion, and in this way the flowing of the fluid will increase and fluid accumulates under the pressure, rarely applying pressure to heart below. So in this way the complication is the tamponade. Anyhow, this is the video about the pericarditis, the pathogenesis and clinical finding. So I hope you make sense about this. In this video, we have discussed about the pericarditis, that is pathogenesis and the clinical finding with the simple diagram to understand as well. So thanks for watching. Next video, we will also understand about the myocarditis.